the OrthoPAC, hosted by Sam Dyer. Welcome to the OrthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Listeners, we're on today with Josh Porter. Josh practices preventative medicine, and he gave a talk recently at our Phoenix conference on obesity medicine and optimizing the orthopedic surgery patient. Welcome today, Josh Porter. Josh is a PA who historically has experience in orthopedics and emergency medicine. During the pandemic, Josh decided to make a career change, and he's now working with obese patients and weight loss. He owns a hormone optimization clinic and doing well with it. Josh, with his background in orthopedics, is also a former board of director member for the PAOS. He served as a Southeast Regional Director and was also Vice President for a time. So, Josh, welcome to our podcast.
Thanks for having me, Sam. I really appreciate the honor to be on here.
Yeah, we're excited to have you. So, some of you might be questioning, so if Josh changed careers and is doing weight loss, why is he on an orthopedic podcast? Well, I'm glad you asked. Josh recently gave a talk at our Phoenix meeting, and the title was Obesity Medicine, Optimizing the Ortho Surgical Patient. So, Josh, I'd like to open it up for your discussion. Can you please tell our listeners what came about that made you decide that you wanted to do obesity medicine?
Yeah, I think probably the larger umbrella of what I do is really preventative medicine, and obesity medicine happens to probably fall under that. And it's a large percentage of my clientele. But really, Sam, I've always had a passion for preventative health. I got my start in healthcare as an athletic trainer in the early 2000s. And, there's a lot of athletic trainers who become ortho PAs. So it probably resonates with a lot of people. But, majority of that training is on preventative health. How do you prevent your athletes and, clients from getting injured? And so I had that foundation. And then as I morphed into a PA and got involved with orthopedics, and where I spent a large majority of my career, as well as emergency medicine, so much of the industry was built around reactive medicine, right? I'm seeing patients for, knee arthritis, shoulder arthritis, hip arthritis, whatever. And so there's very little, there's always trauma and things like that you got to react to. But it seemed like the struggle within me was always, man, if I could have gotten to this patient 10, 15 years down the road. I'm not saying we can cure arthritis, but I'm saying, could we have helped that person prepare with lifestyle behaviors and choices that maybe would have led them to less of a problem when they got a little bit older, or even if it didn't, even if they continued to progress with arthritic changes, their ability to, go through a surgery and recover well and just have a better outcome. So I really now kind of focus on, how do I help people optimize their health span, their quality of life? And again, because so much of my practice in the years past was in orthopedics, I'm very passionate about orthopedics. It's a fascinating field of medicine. So I find myself still invested in that career path as well. And that's why, I think obesity medicine does play a role when it comes to orthopedic surgery.
Josh, I didn't ask you this or write it in the script, but do you get referrals from orthopedic groups? Like when somebody, either you get a gastric bypass or lose weight or do something, I'm not going to do your knee replacement. Do you get referrals like that?
Yeah. Again, it may be an oddity just because I came out of that world within the city I still practice in. And so I have great relationships with several orthopedic surgeons here in town. So I do get referrals for whether it's, hey, can you help me just kind of optimize this patient? They're not a client, they're not a surgical candidate at this point due to some behaviors or modifications, or, hey, we're really trying to help them recover. They're struggling. So I've got several orthopedic surgeons who send me patients just to try to help that client optimize their outcome. So yeah, absolutely.
Great. Okay. All right. Well, let's talk a little bit about obesity in the U.S. Could you please give our listeners some statistics on, and these were kind of very interesting to me.
Yeah.
The number of obese people and the percentages of the population that are
Mm.
obese. And, you listed some statistics on healthcare costs as well. Could you please give our listeners a little bit of overview of that?
Yeah. Yeah. I think it's staggering. And, it's one of those things where it's probably because it's so commonplace now for people to struggle with being overweight or obesity that we just don't really take a step back and appreciate, like, wow, the complexity of this or the staggering statistics. But since 1975, obesity has tripled in our population. So we have it is rampant like wildfire. In 1970, Sam, the average adult male weighed 173 pounds in the United States, and now the average adult male weighs 200 pounds. So you've got, a fairly significant weight gain that you're seeing. One of the things that I practice in my clinic is hormone optimization. So I typically I'm going to see a lot of aging men and women, but one of the most staggering statistics to me is that obesity, as far as just a population of people, obesity is the highest among women between the ages of 50 and 65. And there's a little problem that they go through called menopause that is, kind of the catalyst behind that, which is very frustrating for women because they don't have a good answer as to how what's going on and how do we fix that, which is, again, kind of something I do, but just a staggering, statistic. 42%, this is directly off the CDC website, just so you know, but 42% of the US population is obese, and 76.3% of the US population is currently overweight. And we're defining that, and I think you asked me this a little bit later, but I'll go ahead and explain this. But we define that based off of BMI. And we'll get into the how that works a little bit, but that's where those statistics are coming from, is based off of the BMI of those individuals. And then you start talking about cost. So when you look at some of the studies that are out there, so a BMI between 30 and 40, which would characteristically put somebody in the obese category, is associated. So when you've got a BMI that high, you're going to have about a 50% increase in healthcare dollars. So the amount of healthcare dollars that is spent either treating obesity directly or indirectly as a consequence of that disease is staggering. A BMI greater than 40 is associated with nearly 100% of increased healthcare dollars. So again, it's not to say that obesity is causing all the problems, but it is not helping our goals of helping people, treating people. It's clearly a problem in our society from the population demographics that I shared, and then also just what it's costing us to treat the comorbidity being overweight or obese.
Kind of staggering
Yeah.
statistics. 73% of people are overweight.
Yeah.
My mom used to say that I was big boned, but hey, what are you going to do? I genetically, I'm
Yeah.
predisposed. I need to come see you, Josh. All right.
I can make it happen.
So you mentioned BMI, and I think most of our clinical folks that are listening to this know what BMI is, but
That's
just
right.
for, say, can you talk about that? And then also maybe add, BMI is not the best tool for, measuring
Correct.
obesity,
Yeah.
whatever. Can you talk about maybe some other options like the scans, the DEXA scans, that kind of stuff?
Yeah. Yeah. I think I'm going to start there because I would say, especially for orthopedics, why I don't know how many, we're just more familiar with the DEXA scan. I know a lot of times now, the orthopedic practice I was in before I opened this practice, we had a bone health clinic, right? So we had a DEXA scan that was available to us. But the DEXA scan, in my opinion, would be your gold standard. And it's a, low frequency X-ray that does a great job giving us the appendicular skeletal muscle mass, body composition. So you can use it for so much more than just bone density. But that's not convenient for everybody, nor is it cost effective. Not everybody has a DEXA scan sitting in their office, especially from insurance purposes. You can't really get that covered through insurance. So we use tools that are easier, BMI being one, which is just going to basically use a chart, which is going to take a ratio of your height to your weight and then give you an estimate of the body fat that you have. And Again, is it the best? No. Does it really calculate or take into account, you know, muscle and lean muscle development and things of that nature? Sure, it doesn't. But it's a when you've got something that's easily accessible, it doesn't really cost anything extra to do, and you can apply it to almost everyone. You can start to develop some impressive data, like I shared, that seems to be fairly consistent with obesity and weight gain. Other things that I use in my practice, we use bioelectrical impedance. So we use a body composition scanner. Those are easy. Some people have in-body scans. That's a name of one of those, where you just kind of hold the handles, stand on it barefoot, and it'll measure the current through your fatty tissue, and it'll give you a body composition. And those are very beneficial. In a lot of places now, even in like in my town, for example, a lot of your nutritional stores carry those, and they'll offer those tests for free. And so I use those quite extensively because I can also help some people in my community get business and things like that. So I send a lot of patients for bioelectrical impedance testing, waist to hip circumference. So measuring, the circumference, a little bit more time intensive because you actually have to measure that. That can be a tool. Waist circumference can be a tool just for abdominal obesity in particular. But by and large, I think the thing that is what I wanted to kind of relay to orthopedic PAs at the conference was I don't expect orthopedic PAs to be ordering DEXA scans and evaluating that for lean muscle or body composition. But a BMI can be helpful, and it can at least be a target. And I don't know about your practice, Sam, but in my practices in ortho, we use BMI as a cutoff, right? A1Cs were a cutoff as to when we would operate on somebody, and we would use BMI as well for a cutoff, whether or not we would operate. And so it's a standard practice to use the BMI, and it's a much easier tool for somebody in orthopedics to use that as a way to determine whether or not this patient really needs to kind of seek help or at least consider doing something for their weight.
Well, yeah, the BMI, it's a quick and easy height, weight, and there you go. And you've got a number, and
Right.
it's yes or no based on that. And
yeah, and it's most EMRs, we don't even have to, it's automatically calculated, right? If somebody punches in their height and weight, and it tells us as the provider, here's the BMI.
Yep, exactly. And it's a quick tool, and definitely in my practice, they use it. Listeners, please join us again next week when we continue our discussion with Josh Porter on obesity medicine, optimizing an orthopedic surgery patient. Thank you for joining the OrthoPAC podcast. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.